Well, thank you very much. I'm really very honored to be here, and as you might imagine, I'm kind of an outsider to ultrasound. So when I thought of what I could actually talk to you about and leave you with, I thought maybe it would be most important to hear about my journey to this, and then leave you with some reasons to take back to your leadership to convince them that, like Dr. Clayman, this is the future and we no longer can hang on to the past. So how did I get here? It's kind of an interesting story. And you did hear that I chaired the American Board of Internal Medicine exams for about 9 years. And at the end of that process, our committee sat down and said, well, what's the future? We've now got 9,000 questions and we know that our examinees can pass those boards. But are they really better doctors when they finish, right? We know that exams correlate with smarter people. But we said medicine has really changed. What should we do to make sure that those who graduate actually care for patients better? We could be like Canada. We could have a clinical examination as a hurdle. And then we know that they knew their physical exam. They just wouldn't use it. And that was where we were perplexed. We said, how can we really do things better and create a better physician? And lo and behold, we had a wonderful, well-known nephrologist on our committee who said to us, well, why don't we use ultrasound? Everybody else is using it. What's wrong with you guys in internal medicine? And that's where the idea really stuck. We said we weren't interested in an exam anymore because we knew that people on the exam, when they were cued to hear an S3 or a murmur, they knew the answer. They just couldn't find it on the patient. So therefore, how do we do this better? And that's how I came to the area of ultrasound. And that was in the year 2004. So it's now 10, 11 years later, and we're still working at this. And so what I thought I would do is simply give you 10 major reasons for why we need to do this and why this will change the paradigm of medicine. And I think you will hear some recurrent themes a little bit differently from me. I'm not going to talk about the data because you're going to hear about the data all along. I'm going to kind of talk about where we've been and where we're headed. As you heard, we used to look at patients, feel patients, and that was all we really had to offer them. Everybody was very excited when we now had a tube that we could listen into the chest and actually hear the heartbeat rather than just feeling it. But that was over 200 years ago. Where have we been? So the real reason number 10, is that we do have way better tools in everything we do than we had some 200 years ago. And yet, we are still stuck. We're still stuck believing that we need to invest in hours of education with a stethoscope, knowing that not only novices, but experts aren't very good even when they finish. We know that cardiologists are only about 50% accurate. So what do we do with this black bag that we've had for years with ophthalmoscopes, with otoscopes that we never use, that hang on the wall? And I dare say, if you looked at a medical student or a resident or even a physician of the mid-career level, they have no expertise in using these black bag tools. So we do need a new tool in our black bag. So the biggest reason for doing this is that everything else in our world has changed. How come we're stuck? We need to move forward with a better tool. So you may remember when you spent hours on rounds and the most revered clinician was certain that they had a finding that you couldn't find. I remember this professor all too well convincing me that there was a spleen present. I'm a hematologist, right? I really care about spleens. They're like big lymph nodes, right? Well, lo and behold, there wasn't a spleen present because on post, it was barely phalangeal. It was atrophic. But what about this patient? This patient is the story of how I met Dick Copeland. I'm looking at him. He will remember this. So in 2008, after 4 years of thinking how to move this initiative forward in internal medicine, we convinced Onicide to give us $100,000 in Miami to bring together a group of internal medicine leaders, chairman of the boards, ERCs, critical care societies, et cetera, et cetera. John Kendall helped me think through this in emergency medicine. I met Michael Blivis that way, and Michael said to me, well, you know, there's this guy who's teaching medical students. You should invite him. So I did. And we had about 25 people that were leaders in medicine and about 15 people that were going to speak. And we were going to get these leaders out and put the probe in their hands with standardized patients. Well, lo and behold, this patient was a 45-year-old man who was an actor, but who had been one of our standardized patients at the University of Miami for a couple of years, been followed by a faculty member, a student, and a resident with epigastric pain, and was told that he had epigastric distress, treated with a PPI. He was one of our standardized patients, going to be demonstrated to these wonderful internists about how you can find a spleen and find everything in the belly. The technician has a panic attack. She comes running over to me and said, oh my gosh, I don't know what to do. I just put the probe down and this patient has a splenic lymphoma. Well, if you don't think that sold internal medicine leaders in about 2 minutes about, wow, we could make a difference. We actually saved this patient's life. So we could improve the accuracy of the physical exam. We know that we're only about 50% accurate no matter what we do. And Abraham Berdesi has referred to this as the physical exam and other forms of fiction. This diagram has changed over the years and just reminds us of all the things that we can easily detect without imaging and how we could be such better physicians if, in fact, we advanced what we did with our patients to the physical exam. Might say, why do we do a physical exam? It is actually part of our profession. It's how we connect and engender trust in our patients, the laying on of hands, if you will. In some instances, yes, we do make better diagnoses. And in some instances, actually the history and physical done by a senior clinician is better than all the laboratory tests involved. But the reality is, it is that connectivity to the patient, which we have now lost. We talk about the eye patient at the computer, right? And we don't do a very good job of actually laying on of hands and engendering that trust or of educating our patients. Well, could we do it better? This is a picture of Dr. Bruce Kimura, who in the early 2000s in internal medicine as a cardiologist, a practicing cardiologist in a small training program at UCSD, decided that it was time to take this to the generalists, and he designed the flu exam. And here you have him explaining to his 45-year-old young patient that she has rotted plaque and that her cholesterol and blood pressure need to be eagerly managed. Well, what better connectivity to the patient? So we can connect to our patients in far different ways, really with a hands-on approach and bringing back that connectivity that our patients expect. Well, as many of you know, it was Sonosite that was tasked by the military with coming out with machines that would be indestructible and could be put into the hands of medics in the mid-90s. It took over 10 years before they had 300 of these machines, but it changed the mortality and morbidity of our wars and has made a huge difference in survival, such that the diagnoses are made more rapidly, more urgently, and managed. Well, we know that across the world, ultrasound is the diagnostic tool recommended by WHO in undeveloped countries because we can make life-saving, important diagnoses. Well, what if you could also do this in your office, right? You'd save the trips of all the patients to the x-ray machine. In our rural communities, we would save their travel. Easy enough to see a rib. So, in fact, reason number 7, we will diagnose more quickly for our patients and save more lives. So this is actually a picture of the nuclear explosion in Fukushima, Japan in 2011. Well, one CT of the abdomen and the pelvis is about 10 millisieverts of ionizing radiation, which is actually more than the community experienced in this explosion. So ionizing radiation and the glibness with which we order CTs has not risen to our community consciousness, but really should. Certainly we know that some of the safety of CBP central lines procedures have been markedly improved in novices, especially by ultrasound. But what about this concept? Ultrasound is non-damaging, right? It's a shortcut, could avoid ionizing radiation. 1 in 4 patients will have a CT done this year, and 1/4 of all radiation exposure is due to CTs. So if we could just save a few of these, especially in the abdomen and pelvic area, we would be ahead of the game. So reason number 6, we can actually improve the safety of our practice. Well, we also know that we are the most expensive healthcare system, $8,500 per patient per year, higher than any of the developed countries, less safe, and poorer outcomes. 43 million chest x-rays at a cost of $3 billion are done every year. What if we could just save 10% of those? We know that the use of ultrasound of the lung for the diagnosis of community-acquired pneumonia, both in children and adults, is 90% sensitive and 90% specific. So shouldn't we move to this arena? Will we not save dollars in our healthcare system, especially as we go to global budgets where actually care under the primary care system will be determined by how little you do, not by how much you do to get your patient to a quality outcome.
This is a portable ultrasound. It can plug
Can
into a
everybody hear
smartphone, it can plug into a tablet. Mobisante is up in Redmond, Washington. And they kindly trained me to actually do this on myself. They're not approved to do this. Patients are not approved to do this. This is a concept demo, so I want to make that clear. All right, I got to gel up. Now the people in the front row are very nervous. And I want to actually introduce you to Dr. Batuk, who's another friend of mine. He's up in Legacy Good Samaritan Hospital in Portland, Oregon. So let me just make sure. Hey, Dr. Batuk, can you hear me okay? And actually, can you see Libby?
Hi there, Eric. You look busy. How are you?
I'm good. I'm just taking my clothes off in front of a few hundred people. It's wonderful. So I wanted to see, does this look the image that you need to get? And I know you want to look and see if those spots are still there.
Okay. Well, let's scan around a little bit here. Give me a lay of the land.
All right.
Okay. Turn it a little bit inside, a little bit toward the middle for me.
All right.
Okay. That's good. How about up a little bit? Okay. Freeze that image. That's a good one for me.
All right. Now, the last week when I did this, you had me actually sort of measure that spot to the right. Should I do that again?
Yeah, let's do that.
All right. This is kind of hard to do with one hand on your belly and one hand on measuring, but I've got it, I think, and I'll save that image and actually send it to you. So tell me a little bit about what this dark spot means. It's not something I was very happy about.
Many people after a kidney transplant will develop a little fluid collection around the kidney. Most of the time it doesn't create any kind of mischief, but it does warrant looking at. So I'm happy we've got an opportunity to look at it today, make sure that it's not growing, it's not creating any problems. Based on the other images we have, I'm really happy that how it looks today.
All right, well, I guess we'll double check it when I come in. I've got my 6-month biopsy in a couple of weeks, and I'm going to let you do that in the clinic because I don't think I can do that one on myself.
Good choice.
All right, thanks, Dr. Batuk.
So who's Eric Dushman? He's an executive at a little company called Intel. And he is a patient and doing this on himself. Many of us who live or work with rural communities understand that patients will have this in their home. And what Dr. Clayman talked about is not too far off, especially as we look at the magnitude of data that is going into clouds, can be generated. I would tell you that our own enterprise is at the point where we are imaging molecules. So it is not far off in the future, and patients will have this. So therefore, reason number 4 is we better do it because our patients are going to. We do not have a choice. This is not something we can avoid. So as you also heard, our neuroscience tells us that if we want to learn and we want to create stickiness, we have to do two things. We have to use a multimedia approach to engage learners, and we have to create empathy. That creates stickiness in what we learn and retain. Well, of course, this is a perfect way to create stickiness. Our students are digital natives. They are used to this. And so therefore, we need to engage in this. We cannot leave it out of our curriculum. And you, of course, know that better than I. So that is reason number 3. So reason number 2, like Chris Fox's child, our students will do this. They have interest groups. They will learn it on their own. My own students at OHSU came in 2nd place in the World Cup, having 0 curriculum. 0 curriculum a year ago. They learned it on their own. So why is this important for us? Students do not have the clinical experience to guide how to use this as a tool. To them, it is a learning device and a technology. To us as senior faculty, it is important to integrate our clinical knowledge, our long years of clinical judgment, into figuring out how to use it in the care of patients. It is us who will help them develop the research questions that will help answer the next set of questions. So we cannot leave this to our students, because they will use it anyway, regardless if we, as senior faculty, deans, ignore it. So this is a real reason to actually convince your faculty that they cannot be left out of this. It may feel awkward to them. They may not be able to use their hands in the way that our students can. That is irrelevant, right? I mean, it's this generation that grew up typing when they were 5 years old. Most of you probably can't type if you're my age, right? But that does not prevent us from working together of how to improve and enhance healthcare through the use of much better tools than we've had in the past. So I say we cannot think about the past. We have to remember that it is a different future, and this is not our choice. And when you think about our academic enterprises, we are some of the most conservative, most difficult to move enterprises. It is up to us to not get stuck in that mode. And it's not just one device, it's not just a few companies now. It is everywhere you look, sold directly to the public, to PAs, to everybody who can put one in their hand anywhere. Even if it's transmissible across a line, you can put this into somebody's hand to improve healthcare. So what is reason number 1? Okay. Yes, it is a new tool. And my diagram looks like everybody has their own rendition of this, right? The new tool in the toolbox. But the reality is, we can't wait. I will tell you that there were about 4 years where, as a good internist, I spent trying to do a clinical trial to prove that this was valuable. Well, you can't really prove it's valuable if you don't have the skill set to do it. Nobody proved the stethoscope was valuable or the physical exam skills were valuable. Right? It took us many, many years to find the evidence. So therefore, we will get better as we use it. And that is reason number 1. Do not wait. What keeps us from moving? It is our tradition. It is our wholehearted tradition, the way we were educated, the way we were taught. But it is our love of patients and our care for patients that will allow us to keep the best part of our traditions and move it forward. So I ask you, please think beyond. Think about where the future will be with your students, your faculty, and help move it. So those are my 10 reasons. I think you can write them down and go to your dean, your provost, or your president and convince them. It will help you get through the difficulty of it costs too much, but our faculty aren't trained, etc. There's no room in the curriculum, on and on and on. We must be convinced this is where we need to go and work with it. So thank you very much.